That's amazing.
You're on video right now. Hello.
It's good for diabetics and contact lenses. Have you read that?
Hello.
I haven't read it. Oh, hello. How are you?
I'm Deb.
Prahlad, good to meet you.
These are your judges.
Hey.
Hello. Nice to meet you.
Thanks for stopping by.
You'll have 5 minutes.
Okay.
I'll give you the 1 minute warning.
All right.
And then these 2 minutes to very distracting.
I know. I'm trying this for the first time. I promised to be part of this Google Glass Explorer program because I develop stuff for this. Make on the side also do stuff like this. So.
Okay.
But anyway.
All right.
5 minutes.
Go ahead.
1 minute warning. All right. So thanks for stopping by. Today's study is about heart failure patients and analyzing the motion of their heart using shape as a metric of improved performance after surgical ventricular restoration. Okay, so essentially we start with cardiac MRI data of heart failure patients who are due for surgical ventricular restoration. Analyze the regional motion of the heart from standard cine cardiac MRI. That means the shape of their heart is the only index of how it moves. And then I track the motion history of each point on the surface and come up with a displacement history over time. Average that over time and then plot a displacement history characteristic and benchmark it against a set of normal patients. So our study cohort of heart failure patients had a mean myocardial velocity history characteristic given by this blue line, which was far amplified in comparison with was far diminished in comparison to the amplified motion of the normal controls. Now, after procedures, this mean myocardial velocity was an index of improvement. But the purpose of this study is to say that, we can regionally characterize the motion of normokinetic, akinetic, and dyskinetic territories of the heart and make sure that you can identify those mean myocardial velocity traits as a relative indication of performance improvement. So in the case of preoperative heart failure patients like this, you have the basal region, which is okay, normal contracting. There's a big aneurysm territory which has akinetic and dyskinetic territories, which is telling you in this snapshot of the instant of peak filling rate, this base is moving outwards, the apex is moving inwards, and this is which is confirmed by means of the phase to peak contraction plot, which tells us the same thing. The apex is contracting at a different phase. So now if I took just that aneurysm region and just the base region separately, you'd find that the basal region had a mean myocardial and the aneurysm had a different one. They are out of phase, so that indicates the dyskinesia. It kind of validates the paradigm of using this technique. But what's more fascinating is that once the procedure is complete and there's a patch on this place instead of the aneurysm now, the patch was proven to be akinetic for the first time. Usually we think of it as an elastic thing, but it's akinetic. And you can also examine the improvement in the remote myocardium in terms of the mean myocardial velocity, which shows that it is improved in amplitude during systole and diastole. So this is systole, this is diastole, and this is the preload phase, over time. And so what's better is you can identify improvement in timing, because this green line is a little later in contraction as opposed to the bottom green line post-operatively, which indicates that there is probably better DPDT as well, And so in sum, the remote myocardium seems to be an indicator of the improved myocardial performance, and so you can do shape-based analysis of the heart, starting from cardiac MRI, which is standard, cine cardiac MRI, and come up with these conclusions to identify which patients are responding best to surgical ventricular restoration, just from the remote myocardium. So that's the conclusion of this study. But this study itself has been extended in its value in a presentation that I also presented at the American Heart Association meeting in Dallas last year, to use these shape-based metrics to do virtual surgery and predict the post-operative outcomes. And it turned out that, the predictions are also pretty good. So in this example, we're just doing post-operative follow-ups, but you can use this paradigm for to predict post-operative outcomes. And that's the subject of my AHA beginning grant and aid application, which I just submitted, so it is in review. So, fingers crossed.
Do you do virtual surgery? Do you need a surgeon?
So virtual surgery is guided by the decision of a surgeon. But you can. It's actually operated by a surgeon. So actually, I have this cloud-based platform that allows the surgeon to use a mouse and basically cut off what he wants. And so I right now operate it, but then it's as easy to use for a surgeon as it is for me or even a child, because essentially you're cutting out something that's green. Cut out the green, and you do optimal virtual resection of the territories that are scarred. And then you can analyze virtual postoperative mechanics because you know the preoperative characteristics, and now you know that the volume is reduced, and you model an akinetic patch because you know what it's supposed to behave like from a training data set, let's say. You can pick up what it should be after a procedure. And but that's not the subject of today's talk, of course, but poster, of course. But essentially, you can use this index of mean myocardial velocity not only to compare pre and post operative patients very effectively in terms of magnitude of displacement as well as timing of contraction, but you can also use it to train a method that can predict post-operative outcomes.
One more question?
Putting a big patch onto the heart is one thing, but looking at something more subtle like the effect of drugs or afterload reduction or other interventions probably would even be more valuable. Have you tried to do this with something other than as drastic as putting a patch on?
Well, the only thing I've tried so far which is equivalent is in terms of a percutaneous ventricular restoration device, the Cardiokinetics Parachute. I've virtually deployed that. In fact, Cardiokinetics consulted with my company QuantMD to do that, in fact. But the notion of actually understanding, let's say, stress response or something like that is something that can be done in terms of, say, okay, I know that as a result of stress, this curve is going to amplify in this direction or stretch in this direction, so you can predict what it might look like. But essentially, to train based on what a specific drug response results in terms of a response of mechanics, you need to have a patient set which actually received the drug, and you had the cardiac MRIs, train using that data set, and then you'll know exactly how the variations are supposed to be as a result of the drug. So it is possible to use as a predictor of pharmacological agents, but it needs to be trained for doing that. But if you have the patient data to do something like this, I'd be happy to try, because this is amazing as a potential application, of course.
Thank you.
All right? Yeah, thank you.
Yes, all right.